Let's get started. Welcome everyone. I'm just gonna, while I keep chatting away, I am going to keep admitting people on the side, and I will be putting things in the chat. There's a couple of, there's some, a conference that people might be attending to SIOG very soon. And then also there's some workshops at the conference. So I'm going to put those in the chat, just the information about those if you don't have those. And then I would like to introduce, sorry, I just keep admitting people. I would like to introduce Dr. Papadopoulos. So I know Dr. Papadopoulos, and I hope I'm saying that right. I never call you by your last name.
Yes, that's right.
I know Dr. Papadopoulos from before when he was working here in Canada, but he's an assistant professor now, and we're sad to lose him, but at the School of Kinesiology at Louisiana State University. And prior to joining LSU, he completed a postdoc training in geriatric oncology here in Toronto at the University Health Network. And I know you did a lot of work with Dr. Alibi here. And so while his PhD focused on effects of exercise on clinical outcomes with men with prostate cancer. And now his research down at LSU aims to understand the effects of skeletal impairments on health-related outcomes among patients with cancer, particularly older adults, as well as targeted interventions to improve muscle mass and function before, during, and after cancer treatment. So it's so lovely to have you, and it's so nice to have Allied Health. It's great. So thank you for doing this webinar for us today, and we look forward to hearing your talk. And also, Dr. Papadopoulos, if you want to have people ask questions at the end or during, it's up to you. Just shout out your preference, and maybe people can raise their hand or what have you, because I see there's 37 participants so far, and I have to keep admitting more.
Great. I think, yeah, we can leave the questions for the end. That would work better, if that's okay. So hi, everyone. It's my pleasure to be presenting today one of our recent papers in geriatric oncology, and I would like to thank Reina and Kristen for the invitation. We know that geriatric assessment is recommended for all older adults with cancer to identify aging-related deficits and inform treatment decisions as well as management strategies. The 7 domains that are assessed during geriatric assessment include physical performance or physical function, functional status, nutrition, social support, psychological well-being, comorbidity status, and cognitive function. Now, I would like to focus on physical performance given the topic of the paper. Now, physical performance is an objectively measured whole body function related with mobility. So it's not the same as muscle strength, because muscle strength describes the ability of the muscle to exert maximal force with a single maximal effort. And although muscle strength does not have its own domain within geriatric assessment, some geriatric clinics assess muscle strength on top of physical performance within the physical function domain of geriatric assessment. And for the assessment of muscle strength, the grip strength test has prevailed in clinical practice due to its brevity, practicality, low costs, as well as high reliability. And although the grip strength test assesses upper body strength, it is used as a proxy of whole body strength. Physical performance can be assessed using various tests. One of them is the short physical performance battery, which assesses the patient's balance, usual walking speed, and lower extremity function using the 5-CT stand test. The score for each test ranges from 0 to 4 points, with higher scores representing better performance. And the maximum score of the SPPB is 12 points, and normally a value of 9 or less is indicative of low physical performance. Now, both the grip strength test and the SPPB have been shown to predict outcomes in geriatric oncology. On the left, we see a meta-analysis of approximately 8,100 older adults with cancer that demonstrated that those with high grip strength had a 38% lower risk of all-cause mortality compared to older adults with low grip strength. Similarly, SPPB was associated with a 56% lower risk of all-cause mortality compared to low SPPB. And on the right, we have another study of 515 older adults with cancer. And what we found was that those with low grip strength and or low SPPB had a 77% higher risk of having their treatment modified and Treatment modification in that study was defined as reduced treatment intensity or transition from active cancer treatment to supportive care. Although the grip strength test and the SPPB are predictive of outcomes in geriatric oncology, there are challenges associated with the implementation of both. So a major challenge that relates to the grip strength test is the availability of various clinically relevant cutoffs by several expert groups, some of which are listed here. And as a result, this can create confusion among
Effie, Effie,
Can you hear me now?
Effie. Yeah, just there's people unmuted, so I'm gonna hit the mute all button. Sorry. Can you unmute yourself though? Because I hear lots of background noise.
Can you hear me now?
Yeah, but I'm gonna mute everybody. Sorry about that. And
That's okay.
keep yourself unmuted. So unmute. So you're
Can you hear
perfect.
me
Thank
now?
you. Yep, thank you, Dr.
Okay,
Papadopoulos.
no problem. So once again, there are challenges associated with the implementation of both the grip strength test and the SPPB. A major challenge that relates to the grip strength test is the availability of various clinically relevant cutoffs by several expert groups, some of which are listed here. And as I was saying, this can create confusion among clinicians and uncertainty regarding the cutoff that should be used to identify muscle weakness in older adults with cancer. Regarding SPPB, as I mentioned earlier, it consists of 3 tests. It requires more training, more space and time for clinicians to administer than the grip strength test. And given the time constraints in clinical practice, it is important to understand which SPPB components are more relevant for older adults in the context of geriatric assessment. And so we conducted a retrospective study to identify which grip strength cutoffs were associated with impairments in geriatric assessment domains and an abnormal geriatric assessment. And our secondary objective was to determine whether total SPPB score and 2 of its domains, specifically usual gait speed and the 5-CT stent test, were associated with impairments in geriatric assessment domains and an abnormal geriatric assessment. So this was a retrospective study of older adults who were diagnosed with cancer of any type and had a geriatric assessment at the Older Adults with Cancer Clinic, the O Clinic, within the Princess Margaret Cancer Center. All study data were retrieved from the OAK database between June 2015 and March 2021. The OAK database includes information on clinical characteristics and geriatric assessment domains to inform clinical programming and optimize patient care. Participants were included if they were at least 65 years old and had a geriatric assessment prior to cancer treatment, while those with incomplete information on muscle strength and physical performance were excluded. So we retrieved information on patients' age, sex, cancer site and stage, treatment intent, and geriatric assessment domains. All geriatric assessments were conducted by experienced clinical nurse specialists and a geriatrician, and this table lists all the domains that were assessed during geriatric assessment. So the Older Americans Resources and Services was used to assess instrumental activities of daily living. The CATS ADL index was used to determine activities of daily living if a patient was dependent in one or more instrumental activities of daily living. Physical performance and muscle strength were assessed through the SPPB and the grip strength test, respectively. Comorbidities were assessed using the Charlson Comorbidity Index. For nutrition, the clinic uses involuntary weight loss of 5% or more over the past 6 months and BMI information. Cognitive function was assessed using the MiniCog. The patient health questionnaire was used to assess mood. Social support was determined through specific questions about home environment and formal and informal supports. while patients' medication were reviewed by the clinician to determine whether medication optimization was required. Now, both the grip strength test and the SPPB were assessed by clinical nurse specialists using standard procedures. For the purposes of the analysis, we used 3 different cutoffs to define low grip strength as follows. So according to the FNIH, the cutoff for low grip strength in men is less than 26 kilogram, and for women is less than 16 kilogram. The European Working Group of Sarcopenia criteria in older people uses the same cutoff for women. However, for men, the cutoff for low grip strength is less than 27 kilogram. And lastly, the Sarcopenia Definitions and Outcomes Consortium, SDOC, defines low grip strength as a value of less than 35.5 kilograms for men and less than 20 kilograms for women. For total SPPB, a score of 9 or less was used to define low physical performance, while abnormalities in usual gait speed over the 4-meter gait speed test and the 5-CT stand test were defined as a score of 3 or less out of 4 points. Now, it is important to mention that the exact time to perform the 4-meter gait speed and the 5-CT stand test was not recorded in the OAK database. However, only the scores for each SPPB component were available. Now, study outcomes included impairments in individual geriatric assessment domains, as well as an abnormal geriatric assessment defined as having at least 4 or more abnormal domains, or geriatric assessment with abnormalities in cognition, comorbidities, and false risk. And this definition was used as it has been shown to correlate best with oncologic treatment impact. In other words, treatment plan modification per previous work. Now, to test the associations between each low grip strength definition and geriatric assessment domains, including abnormal geriatric assessment, we used logistic regression adjusted for age, while in a sensitivity analysis, we stratified for sex. The associations between low total SPPB score and geriatric assessment domains, including an abnormal geriatric assessment, were also examined using logistic regression adjusted for age and sex, while the same analytical approach was used when 2 components of the SPPB, specifically the 4-meter gait speed and the 5-CT stand test, were used as predictors of geriatric assessment impairments. So a total of 475 older adults were included in the analysis. The mean age was 80.7 years. Almost 43% of the participants were females, while gastrointestinal cancer was the most common disease type. The majority of the cohort had an abnormal geriatric assessment, specifically 57.1% of participants, meaning they had at least 4 abnormal domains or abnormalities in the domains of cognition, comorbidities, and false risk. The mean grip strength score was 23.4 kilograms. Next, we see the proportion of patients with low grip strength according to different definitions. So 35.2% of participants had low grip strength based on the FNIH criteria. A slightly higher proportion, 39.2%, had low grip strength per the European Working Group of Sarcopenia criteria, whereas the highest proportion of participants with low grip strength was observed after using the SDOC definition, and that was 75.4%. Moving on to the SPPB, where the average score was 7.7 out of 12 points, 63.3% of participants had low SPPB, defined as a total score of 9 or less out of 12 points. 43.6% had slow 4-meter gait speed, while 81.2% had an abnormal 5-CT stand test. Information about the 4-meter gait speed and the 5-CT stand test was available for 362 participants out of 475. And here we see the table that lists the age-adjusted associations between the different grip strength definitions and impairments in geriatric assessment domains. So the European Working Group of Sarcopenia in older people criteria for low grip strength were associated with impairments in 6 geriatric assessment domains, specifically false risk, nutrition, cognition, social support, instrumental activities of daily living, and medication optimization. Additionally, the European Working Group of Sarcopenia criteria were associated with an abnormal geriatric assessment, which we can see highlighted in green in the last row. The FNIA's criteria were associated with impairments in 5 geriatric assessment domains, which included false risk, nutrition, cognition, instrumental activities of daily living, medication optimization, in addition to an abnormal geriatric assessment. Lastly, the SDOC criteria were associated with impairments in 4 geriatric assessment domains, and these were false risk, cognition, instrumental activities of daily living, and medication optimization. And the SDOC definition was also associated with having an abnormal geriatric assessment. Now, according to the area under the curve, the FNIH criteria had comparable performance with the European Working Group of Sarcopenia criteria, whereas the lowest performance was observed using the SDOC definition. Additionally, the FNIH criteria had the best performance in identifying an abnormal geriatric assessment. And here we see the age and sex-adjusted associations between total SPPB, 2 of its components, and impairments in geriatric assessment. So low SPPB was associated with impairments in 5 geriatric assessment domains, including false risk, comorbidities, cognition, instrumental activities of daily living, medication optimization, in addition to an abnormal geriatric assessment. Slow 4-meter gait speed was associated with 7 impaired domains, basically all except from social support, and it was also associated with having an abnormal geriatric assessment, while having an abnormal 5-CT stand test was associated with impairments in 3 geriatric assessment domains, in addition to an abnormal geriatric assessment. We found that slow gait speed had comparable and sometimes better performance in identifying impairments in geriatric assessment compared to SPPB. And lastly, of the 3 tests, slow gait speed had the highest performance in identifying an abnormal geriatric assessment. We also performed an exploratory analysis to assess whether the addition of the grip strength test into the model improves the performance of the SPPB, the 4-meter gait speed, and the 5-CT stand test in identifying an abnormal geriatric assessment. And this exploratory analysis was adjusted for age and sex. So down here, we see the area under the curve in the base model with SPPB as the predictor variable, and we see the area under the curve is 0.695. And up here, we see that the addition of grip strength to the model improved the area under the curve. It went up to 0.745. And this pattern was observed for both the 4-meter gait speed and the 5-CT stand test. So adding grip strength the grip strength test into the model improved the area under the curve. And we can see that the model with the 4-meter gait speed and the grip strength test had the best performance in identifying an abnormal geriatric assessment. So 2 study limitations I would like to highlight. First, the way we define abnormalities in the 4-meter gait speed and the 5-CT stand test, as the exact time for both tests was non-recorded in clinical notes. So instead of time, the score out of 4 was reported for most participants. And another limitation is the lack of BMI data, given its relationship with grip strength scores. So in conclusion, muscle weakness using the FNIH criteria may better indicate geriatric assessment abnormalities among older adults with cancer, and our results also question the necessity of examining the SPPB in the clinic, given the comparable and for some geriatric assessment, better performance of the 4-meter gait speed. And I would like to thank Dr. Alibi, Sol Coving, Reina, and Susie Mangino for their help with this study. And thank you all for your attention.
Amazing, thank you. Does anybody have any questions? I have one, but if anybody wants to jump in, please feel free. See if there's any hands up. No. How about I'll start it off and then type your questions in the bottom. Oh, Susie will have a question for sure. Go ahead, Susie. Otherwise, I can ask. I have one. For you. Are you able to unmute? No? Oh, no. Allow participants to unmute. Try that. Can you unmute yourself?
There we go. Okay. Hi, nice to see you.
Nice to see you.
And great to hear the results of this. So are you saying that we should just be doing 4-meter gait assessments kind of for
This is a
SPPB?
good question. This is a
Because
really
the other thing I find is like for the chair stand, like that's measuring a very different like it's looking at their lower legs and their balance, and like it's a bit different what we're assessing. So the overall score might mean one thing, but the actual individual tests give us a sense of what kind of like rehab or physio they might benefit from.
Absolutely. And actually, everybody has the same question. I see a lot of comments, people saying, yeah, I have the same question. And I agree because balance, the balance test will focus on balance. And the 5-CT stand test, is it a muscle strength test or is it a physical performance test? Well, there's a debate on that. I think it's more of a physical performance test. But regardless, I think the message is if there is no time, let's say, for example, and you had to pick 1 out of 3, given its predictive ability, maybe the 4-meter gait speed is preferred. But of course, total SPPB is more informative.
Okay, that's really helpful. Yeah, and I think for sometimes it's unfortunate because sometimes if patients don't bring their walker or their cane, then we're actually not doing the walk. And we're doing just the other 2. So it's interesting because sometimes that's the one that gets missed. So great point.
Dr. Papadopoulos, there's a question in the chat for you. I can read it, but you might want to read it so that you are able to answer it. The SPPB includes
comments, sorry.
Yeah, the SPPB includes the 4-minute walk and the 5 by STS and balance component. So are you feeling, sorry, mine is jumping up and down.
So are you feeling that either the 4-meter walk give the most important information to predict deficits in geriatric assessment compared to the balance? I mean, that's another really good question. So in general, because balance is important, and I'm sure balance will predict impairments in falls risk. Now, typically the 4-meter gait speed and the 5-CT stand test are more robust predictors of adverse outcomes in general compared to a balance test. So now balance components, are you feeling that either? I'm just reading the question again. So potentially, but again, balance also provides important information related to falls risk. Or additionally, the instrumental activities of daily living as well. But once again, if there is if time is limited and you had to pick 1 out of 3, which one would you pick? Probably based on our results, the 4-meter gait speed.
So that was my question, sort of what should oncologists, or what would you recommend to oncologists? But it sounds like it's the 4-meter gait speed over any of them, if you had to pick one?
If you had to pick one, yes.
Is there any data to correlate the 4-meter walk test with treatment tolerance or toxicity?
We're currently working on an analysis on that. And data related to toxicity are scarce, so we definitely need more information on this research topic. Mainly, we have the relationships between 4-meter gait speed and all-cause mortality, right? This is well established, or other adverse outcomes such as falls, hospitalizations, but data on toxicity are very limited.
Are there any other questions? It's fantastic.
I would think that like toxicity is going to occur no matter what, but someone's ability to sort of bounce back or like sort of, you know, rehab post some kind of toxicity would be affected by that. Is that accurate? We don't know.
And the other thing I just want to highlight that I think it's important, we examined these three different grip strength definitions, right? And again, the goal was to identify which of those three definitions is the most relevant in the context. Here's the important thing, in the context of geriatric assessment. Do they predict toxicity? We don't know. Do they predict falls, hospitalizations? Then we would need to examine cutoffs that are specific to outcomes, the outcomes of interest.
Great.
Whether that's toxicity or falls or whatever that might be.
Does anybody, I have another question. Does anybody else have any questions? I don't see any in the chat. So I'm not sure this is I don't know if you can answer this one, but Dr. Papadopoulos, how might your findings change how we screen for frailty before cancer treatment? And I know that's a big one. Just, I don't know if you have any sort of ideas or tips. That's a big one.
Well,
Sorry.
I'm kind of biased because I'm an exercise physiologist by background, and so it depends because we have so many different assessment tools for frailty.
Yeah.
And so I prefer the freeze criteria where muscle strength is assessed, slowness is assessed, and then out of 5, those who have 3 or more are classified as frail. Yeah.
Right.
But now,
there's
of
so
course,
many-
that requires more time. Instead
Yeah.
of giving a questionnaire like the clinical frailty scale, it's more, you can just administer that questionnaire and you can determine whether a patient is frail or not within like less than a minute, where all the other tests need more time.
Right. Because there's so many tools out there, such as, you know, the G8, the S13, the modified, all those. So it's so challenging for clinicians to decide which to use and how to assess, but it's nice to have your expertise. There's a question here. How do you reconcile discordance between grip strength cutoffs and SPPB performance in practice?
Okay. So are you referring to the lack of agreement between the two? Grip strength, cutoffs, and SPPB? And if so, lack of agreement. I think if you could rephrase your question, that would be helpful.
Nabila?
I'm not exactly sure. I'm not exactly sure what you mean. Sorry.
Maybe Nabila can rewrite it in the chat. That would be helpful. I have a question. Discordance between the two, between grip strength cutoffs and SPPB performance in practice. The differences between the two?
I get in cutoffs. So again, I'm not sure if you mean that for SPPB, we have a cutoff that's typically 9. Sometimes the European Working Group of Sarcopenia uses 8 points out of 12. Some other studies, some other clinics use 9 out of 12. So that's more, there's more of an agreement with respect to the cutoff that we should be using to identify patients with low physical performance. Whereas for grip strength, we have different cutoffs. I'm not sure if that's what the question is. And how do you reconcile discordance? Yeah, I'm sorry, I'm not sure if I understand the question.
Yeah. Okay. Okay. Maybe. Okay. Well, if Nabila wants to retype it or come back on come on camera. There's a question. I used to use the 6-minute walk test for the adults. By any chance, do you think if the 4-minute walk test is not enough for assessing the difference in their performance in the case of a healthy elderly person?
So the 6-minute walk test assesses cardiorespiratory fitness indirectly. It's a very different test, whereas the 4-meter gait speed assesses, it's a gait speed test over 4 meters. So if the goal is to assess physical performance, the 4-meter gait speed is more than enough. We don't need the 6-minute walk test unless we're interested in functional capacity, unless we're interested in cardiorespiratory fitness. Again, that's an indirect measure of, in case we cannot do a VO2 max, which is more cumbersome, of course, and more expensive, it needs more resources, etc.
Okay. And somebody wrote the 6-meter walk test is important to assess.
I agree with Berenzera. Yes, exactly,
Okay.
exactly. So for risk stratification, many studies, particularly in prehabilitation, they do either a VO2 max test. If that's not possible, then the alternative is a 6-minute walk test. The 6-minute walk test is widely used in the preoperative setting to assess the patient's fitness. And then, of course, you can monitor changes after a prehab intervention, prior to surgery, and after surgery to monitor changes in recovery.
Somebody wrote, just a consideration, not really a question. As Dr. Papadopoulos stated, applying standard criteria based on a general population reference values in SPPB and hand grip evaluation in the geriatric patients with cancer is challenging. I think we need to work on a more personalized approach to better evaluate our patients.
And I agree with that, of course, yes. Yes, because most of these studies have derived these cutoffs and have not included patients with cancer. Yes. That's a very good point.
Yeah. And I expect some of this research to go into clinical practice from your expertise, Dr. Papadopoulos. In your results, from memory, the SPPB had a lower AUC than the 4-minute walk test or the 5 times sit to stand when tested individually, despite each being, I understand, 2-3 individual components of SPPB. I was wondering how that statistically could happen. Sorry, mine's cut off. 2 of 3. Okay.
Sorry, I'm
You read the question.
sorry, okay. Just trying to go back to the, I believe this is the slide, SPPB, yes. Okay. I'm reading the question again, sorry. So SPPB, yes, had a lower area under the curve when we looked at abnormal geriatric assessment compared to the 4-meter gait speed and the 5 sit to stand test. Well, it had higher, SPPB had higher area under the curve compared to the 5 chair stand test. Okay. How that statistically could, yeah, I think it might be because of the addition of balance and 5 chair stands within the SPPB that changes the area under the curve. Somebody would expect that the SPPB, given that it assesses more domains, more tests, it would be a more robust predictor of an abnormal geriatric assessment, but that's not what our results indicated. That's fine, my memory. Oh, okay. Yeah, thanks for clarifying in your comment. Reina, you're muted.
Does
Yes.
anybody, yeah, this is great. I love the discussion. Does anybody have any more questions? I'll wait for them to be in the chat. I'll wait it. So far, looks like no, I don't think. Well, Dr. Papadopoulos, do you have anything else you want to add? This is great, thank you. It's amazing. Oh.
No, thank you all for your attention. That was great.
I'm so So happy to have you here today. And we had, people are sort of leaving, but we had 56 on Zoom. So this is fantastic. So thank you for your expertise. Lovely to
Thank
see
you.
you
Thank you for the
again.
invitation.
Yeah. And for those of you at SIAG, are you going to SIAG, Dr. Papadopoulos?
I am.
Great. Great. Okay.
Looking
So for
forward to
those of,
see everybody there.
yeah. Thank you everyone for
Thank you.
joining. And see those who are going to the conference, fantastic. Have an amazing time. Thank you.
Great. Thank you.
Bye-bye.
Bye.